common nutritional that dietitians follow whenever it comes to putting a CVD patient on a diet. Typically, we go for two main practices. Number one is the TLC diet, and number two is the DASH diet. First of all, let me introduce what a TLC diet is. A TLC diet is a therapeutic life changes diet. And from the name, you can already tell that it focuses on the physical activity. So that is one very important point. Then it focuses on the macro and micronutrients, meaning carbohydrates, fats, as well as proteins. Then it also focuses on the soluble fibers. The question here, why specifically soluble fibers? Basically, whenever the patient consumes soluble fibers, what it does is that it kind of counteracts or kind of lowers the absorption of cholesterol in the body, which is great because our CVD patients typically have high levels of low density lipoprotein cholesterol, which is what we want to rid them of. And then last but not least, which is I think is the most important point that's very much not stressed on typically, which is the phytosterols. Phytosterols are very closely related to cholesterol. How, you might be asking? Simply, it mimics the cholesterol in its chemical structure. So I love this figure, which can help you understand how the process goes exactly. Towards the left, we have our cholesterol that gets absorbed by the absorption sites normally. However, on the right, it shows you how the phytosterols are there. They bind with the cholesterol molecules and they mimic them in shape. So now they get absorbed by these sites instead of the cholesterol, which reduces their absorption, meaning that they kind of do some sort of competing for the absorption site. Typically, these phytosterols or plant sterols are found in food sources like the broad beans, like the soybean products mostly. And just a little tip, it is very much efficient whenever you consume it with other foods, so not on its own. So let's say a full meal with the full components, and you just have to add the phytosterols there. Then the second nutrition practice is the DASH diet. And pretty much everybody knows about the DASH diet by now. We start giving it to patients who have hypertension at the very beginning. And it stands for the dietary approaches to stop hypertension. It starts with number one, a focus on increased fruits and vegetable servings. Now, by increased, we're referring to about like 2 times the amount that a regular person or a normal healthy person should be consuming. So you and I, should be consuming around 5 servings of vegetables and fruits per day. However, our patients that are placed on a DASH diet should go up to 8 or to 10 servings. Then our second point is low-fat dairy products. Why? Because simply fat or saturated fats are what you can find in the full fat dairy products, which is what you want to avoid. Why? Because saturated fats can increase the amount of LDLs, which is the light or the low density lipoprotein cholesterol in the body, which you want to decrease. Because again, the cholesterol can end up, just accumulating, leading to atherosclerosis, hypertension, and then from there, the sequence just starts and the case develops furthermore. Then, increased plant-based protein, include nuts and seeds, about 4 servings per week, and then a high potassium diet, a low sodium diet, which is extremely important. Why? Because hypertensive patients typically have a high sodium consumption. And so you want to lower that in order to help it. And you also want to increase the potassium to counteract that effect. Okay? Then you have adequate amount of calcium for the contractions and adequate amount of magnesium, which could already be found in the nuts and the seeds. Now, this is a little activity that I want to do with you all. If you look at this is basically just packed hot dogs. Do you think that it contains high levels of sodium? Could you type in the chat, please? Okay. Yes. Why? because it's processed. So just the food going through the processing procedure leads to increased amounts of sodium. Now, let's go to the second example that we have here. Hold on, it's not. Okay, our second example, which is packed pudding. Do you think it contains a large amount of potassium? Okay, the answer is yes. Now, here's the trick. Not every food that you consume that has a high amount of sodium is typically salty. That has nothing to do with the saltiness. So sodium chloride, الملح اللي احنا we typically and usually consume, is salty in taste. And so this is how you tell, okay, there's a lot of sodium here. But however, whenever the food is packed, there are preservatives, it has been processed, just to increase the shelf life, they add sodium and to stabilize it as well. So this is rich in sodium. Next up. Now, hence to keep in mind before we get into our case, you need to focus on the sodium, you need to focus on the potassium, the saturated fat because of the LDLs, the processed foods because of the high amount of sodium, the omega-3 because it has anti-inflammatory effects, and last but not least, the MUFAs. Now, MUFAs could typically be found, which are monounsaturated fats. They're found in olive oils, mostly. They do have an anti-inflammatory effect, as well as they have the potential to raise the HDL, which can counteract the effect of LDL. Now let's get into our case study. This is, a typical case study. You take the history of the patient, what happened with them, the lab values, what the medical doctor has perceived, the 24-hour dietary recall, which is what the dietitian's main role focuses or centers around. I have summarized it all here, so we don't have to go through all of the paragraph that you've seen before. Our patient's name is Yasir Ahmed. He is a 61-year-old male who's from Lebanon. This is his weight, this is his height. We calculate the BMI. Now, could you tell me the equation that we use to calculate the BMI? If anybody is aware, in the chat. It is usually exactly. Thank you, Ella. It is the weight in kilograms over the height in meters square. Thank you. Now, as you can see here, the BMI is class 1 obese. Next slide. Okay, we've done the medical examination. This is the medical doctor's role. Yeah. Now we get to our game as dietitians, which is the patient's 24-hour dietary recall. This can tell us a lot about the patient's, let's say, daily food consumption. Now, obviously, sometimes there could be like a specific, let's say, event that happened during that day that altered their food intake. So we asked them if the day before was actually representing the usual intake that they typically have. So here, if you can see, in the AM, in the morning, they had a cup of coffee, they had oats, and I have highlighted the things that are wrong with the diet. Now, you might be saying now, okay, why are oats considered like, let's say, a red flag in this 24-hour dietary recall? Simply because, yes, it is a soluble fiber, it is great, but however, it has instant packet. And as we mentioned before, whenever it is instant, processed, packaged, packed, then it has high levels of sodium probably. Then we have 1 teaspoon of margarine, which is saturated fats. We have a glazed donut, glazed meaning they add fat as well as sugar. Then we have a can of tomato soup. Canned foods or canned items are also rich in sodium. We've got biscuits, we've got butter, we've got also glazed carrots. We've got a ranch style dressing, which is also rich in fat. And then last but not least, they ended their day with 2 butter pecan ice cream. Now, if you look here, it's not only high amounts of fats, but it's also lack of vegetables and fruits. This person is consuming a lot of, let's say, packed foods, high in sodium, fats, instant, ready-made, but however, they're not including lettuce. If you can see here, they're only including lettuce and spinach, crouton, towards their PM meals. And just even when they included the carrot, made or they added glaze to it. So it lacks a lot of fruits and vegetables and just so many aspects of the DASH diet. And we asked if this patient went through previous nutrition therapy. Now, nutrition therapy is when the patient sits with a dietitian or generally any educator that tells them about the situation. And I cannot stress enough how important this point is, because the patient needs to be updated. They need to know what's going on. They need to know once they are let free and you're not following up with them anymore as a healthcare professional, what should they be doing on their own? So you should be explaining that. So here comes mainly the role of the dietitian whenever it comes to food consumption. Obviously, there are a lot of lab values that we've have administered and we got, but my focus here, or the lab values that I've attached, are mainly the lipid profile. So as you can notice here, the cholesterol, is quite high. The HDL levels are low. The VLDL, the LDL are high, and then you have the ratio is quite high. So this also refers that we have, or this shows that we have dyslipidemia. And then here we have triglycerides amount is also high. Okay. Now, this patient, let's keep in mind that they have had a myocardial infarction. They went into the hospital, they underwent surgery, they got hospitalized. Now, from here, the dietitian's role is to put them on the right diet, right? So at the very beginning, we put them on NPO, which means nothing per oral, because the patient is very much fatigued. They cannot even eat. They cannot do exertion. They cannot force themselves or act or, let's say, apply any pressure on their bodies. They suffer from shortness of breath. They cannot breathe well. So eating is quite literally the least of their, let's say, interest at the moment or thoughts. And then they are also extremely just drained after the surgery. So now, once you introduce the foods into their diet, it should be restricted to liquids or clear liquids, then you go to liquids, and then you go to soft diets. Keep in mind that no caffeine is allowed. Why? Because of aspiration, as well as the risk of just disturbed, or let's say fast and slow heart beating and heart rhythm, as well as vomiting, and just so many side effects. So it's better to avoid it. And then we aim mainly for a soft food diet, because we want them to have the least amount of exertion, the least amount of pressure while they chew, while they swallow. So foods like nuts are not a part of the diet. Foods that are hard in consistency or just overall hard to chew. All right. Next up, list the risk factors indicated in his medical record that can be addressed through nutritional therapy. The main issue here is the weight, yes, of course, but also we have an abnormal lipid profile. The main focus is really the abnormal lipid profile, because eventually, if you're fixing that, the weight issue is going to be changed. And it is not the main issue at this stage. All right, this is also the dietitian's role, where she sets or he sets a realistic goal. So let's say my patients in this case had a BMI of 30. I will not be telling them that I want to take them down to 23, because that's not realistic. They'll feel quite, just deprived. They'll feel very demotivated. It's just not realistic to set. So we always go for a little lower. So in this case, 30 down to 25, 24, that's a good range. And then from there, if I need to take them lower, I can do that. But that's a second goal. Next, this is also when you calculate the amount of energy that is needed by the patient, or sorry, the amount of energy that the patient needs to consume. Here, we're calculating the amount of energy post-surgery, after the patient has left the hospital. As you can see here, we use an equation known as the Mifflin equation. We got the amount of the calories, which is 1,786. And this amount is the amount that they, let's say, burn, or it is the amount, or let's say it's expanded while they're just sitting at rest. Now here we have physical activity because, as they have told you about the case, this person has a sedentary job, but however he walks his dog outside for 15 minutes, which leaves us a factor of around 1.3. And then we add a stress factor, and to be more specific, an injury factor here, because they still underwent surgery, they haven't fully healed yet. So you want to also increase the amount of calories so that they are quite like the food losses are replenished. So here you can see it's 1.2. Then for protein, a normal regular person takes from 0.8 up to 1 grams of protein. But in this case, we're going to raise it up to 1.1 grams of protein per kilogram of their body. Why? Because they already are losing, like their muscles are wasting, they're not eating well, they're not able to sustain a regular, or let's say a recommended diet. So we increase the amount of protein. Here, this is also a repetition about what we have said before. In order to fix these lab results, we need to focus on increasing the HDL levels, lowering the LDL levels by consumption of omega-3 fatty acids, by MUFAs like olive oils, and that's it. Sorry. How is any of this being taken care of by a dietitian? Yani there has to be a set of steps that she has to follow, or he has to follow, in order to track the progress from the very beginning, and then assess, and then at the very end to evaluate if the target has been met or not. This is where we go for the nutrition care model. We do something known as the PES statement. The PES statement is what helps you to always remember your goal and then to go back to it. So PES statement stands for, P is an abbreviation for the problem, and then E is for the etiology, and S is for the signs and the symptoms. So here, we need to look at the problems that we have, and then to write a PES statement, and then to start to follow up with our patient. So here, for the intake problem at this point is excessive saturated fat intake, which we already recognize and know from the 24-hour data recall, as well as the lab values that prove it. So we say excessive saturated fat intake related to undesirable food choices, as evidenced by the 24-hour data recall. For the behavioral domain, where there is an issue with the behavior of the patient that we need to also work on, typically by counseling them, by sitting with them and talking to them about how they could change it or alter their behavior, we wrote food and nutrition related knowledge deficit, because they haven't had any sort of previous nutrition therapy, related to no previous nutrition therapy, as evidenced by the patient interview. And then for our clinical domain, which is usually something that like has to do with just lab values, accumulated problems, we have altered nutrition related lab values related to excessive fat intake, as evidenced by the low HDL, the high LDL, and the high ratio with them both. So now our first one, we look at the goal, which is to reduce the fat intake, and then we do our intervention. For a second goal, it is to increase the patient's knowledge, to educate them, to counsel them, and then how we intervene with a situation. And for our last one, which is to normalize their lab values, and that is also done through nutrition. Last but not least, now we go for the menu planning. In this case, as we've mentioned, we have to follow a soft diet. So they're still at the hospital. The hospital is what serves them, is the place where they get their food from. So it's all under the control of the dietitian, the medical doctor, and just the medical team overall. Here in our macronutrient distribution, we have given this patient 50% carbs, 20% protein, and 30% fat. Now you might be asking, why are we aiming for 30% fat, even though the problem with or the main issue here is the high amount of lipid. The amount of lipid remains as is, but we now can control the amount of saturated fat by decreasing it, the amount of MUFAs, and the amount of PUFAs. So this is our game, just to change the percentages, to change the fractions and to play with it. But the end goal is 30% that has to be met. You see this table? This is done on the dietitian's end, where we distribute the exchanges, and then we come up with the actual diet plan that gets translated to our patients. So what I want you here to focus on is, if we look at carbohydrates, we limit the milk or the dairy consumption to low fat, because again, we want to avoid saturated fats as much as possible. Non-starchy vegetables, I'm not sure if I can highlight. Okay. The fruits and non-starchy vegetables both together add up to 10. So 4 and 6, which is what we mentioned at the very beginning. We want to increase the fruit and vegetable intake. And then for the meat substitutes, we went for 6 exchanges of lean protein meat. Why? Because it's a soft diet. You want to make it easy for the patient to chew as well as swallow and just eat overall, with 1 medium fat protein. And then for our fats and oils, this is where I told you it remains 30%, but we just play with the fractions. So here we gave 15% of MUFAs, which is anti-inflammatory, increases the HDL. Example of it is olive oil. We also increase the PUFAs, and we decrease saturated fats down to 1 exchange, which is 5%. 1 exchange, by the way, is about a teaspoon of, let's say, butter. Okay. So for our breakfast, because we need to obviously keep in mind that if our patient is Middle Eastern, the diet should be very much customized and just very individualized. So our patient is Lebanese, so we try to include Lebanese dishes as much as possible. Starting with our breakfast, we just went for the basic egg toast with olive oil and a side of orange juice. And then for our first snack, we went for a banana and chocolate milkshake. For lunch, we went for chicken and rice. And I want you to all notice that we always aim for cooked vegetables more than, let's say, raw. Why? Simply because our patient is not able, again, to chew and then to also swallow hard items that might cause them to choke or might just cause them to exert more pressure than needed. Okay. For our second snack, we added mushroom soup with pita bread. The question here might be, why are there so many snacks? Why are there so many meals? Simply because a soft diet is low amount of food over so many meals. So you distribute, let's say, about 400 grams per meal, so that the patient doesn't, feel uncomfortable. And then you just distribute that over many meals throughout the day, typically 6 meals. So mushroom soup with pita bread for a second snack. For the dinner, we went for sayadiyya, which is rice, salmon, steamed vegetables, and for the flavor, we added reduced fat butter. Our third snack, we just went for pudding with raspberries and chocolate syrup. That is all. Thank you very much all for listening. If anybody has any questions, please let me know.
شكرا ملك. واضح ان انت مش طالبة، ده انت اخصائية وبروفيشنال، وليكي موقع هو على الفيسبوك وعلى الانستجرام وعلى الجيميل.
Thank you.
واضح ان انت بتشتغلي، مش طالبة بس، اكيد انت بتشتغلي في مستشفيات.
تسلم بروفيسور.
بتمارسي